Hey, I'm Jibi, Mathew, nurse practitioner, currently working in primary care in Right Focus Healthcare LLC. Today, I'm doing a quick review video of asthma management for primary care nurse practitioners. Regarding my clinical nurse practitioner experience, I have worked with pulmonary physicians as pulmonary nurse practitioner for 3 years. How do you define asthma? Asthma is a chronic inflammatory disorder of the bronchial mucosa that causes bronchial hyperresponsiveness, constriction of the airways, and variable airflow obstruction that is reversible. Let us discuss some pathophysiology of asthma. What happens when the patients are exposed to allergens? The allergens activate the immune system, immune activation, and IgE production, and it leads to mast cell degranulation, and then it creates vasodilation that leads to impaired mucociliary function in the lungs, and then bronchial smooth muscle constrictions and thickening of the airway walls that leads to airway trapping, which leads to airway obstruction. But on the other hand, the cellular infiltration happens on the right side of the page. It's 6 to 8 hours after the allergen exposure. So neutrophil lymphocytes eosinophils appears about in the latent phase. That also leads to epithelial desquamation and fibrosis that leads to airway obstructions. How do we diagnose asthma? Number one, history of patients' allergies. Are they allergic to climate? Are they allergic to dust or cigarette smoking or passive cigarette smoking exposure, paints or fumes? In the number two, the recurrent episodes of cough, dyspnea, and wheezing, cough with or without sputum, and what provokes their symptoms, how many nighttime awakening with symptoms, how many times a week. Number three, can they tolerate exercise, how many stairs they can climb without being short of breath. Global Initiative of Asthma or GINA defines asthma as symptoms plus FEV1 FVC ratio less than 75 to 80%. And when we look at the spirometry test, FEV1 FVC ratio normal is equal to or greater than 70%. Abnormal is less than 70%. I'm not going detail on that because asthma classification in clinical settings does not go by always as FEV1 FVC ratio. And a spirometry test, if FVC and FEV1 equal to or greater than 80% is normal and less than 80% is abnormal. So another method of in primary care is that peak flow meter may be sometimes available in some primary care offices. 80 to 100%, which is a reading in green zone, that means asthma is in good control. Yellow zone means 50 to 80%. That signals caution. That means we need to do urgent therapy or we need to refer to the pulmonologist. Red zone, we don't get it all the time in primary care because by the time, most of the time, the patient's already diagnosed in emergency room or by a pulmonologist. They always come for the follow-up. Let us do the classification of asthma. The asthma is classified into intermittent asthma, mild persistent asthma, moderate persistent asthma, severe persistent asthma. So by looking at the table, I don't want it to be confused. The easy way to look at it is symptoms and the SABA use. Symptoms, if it is less than 2 days a week, and SABA use, which is usually Ventolin or ProAir, less than 2 days per week, it's intermittent asthma. Most of the times, the other parameters like nighttime awakenings, interference, and the pulmonary function test, which we may not be available in primary care, would always match with those things. And then mild, greater than 2 days a week, SABA use greater than 2 days a week, moderate persistent asthma, daily symptoms, which is short of breath, cough, and wheezing, and SABA use, which will be daily but not several times a day, and severe persistent asthma. Throughout the day, the symptoms will be there, even if they are on controllers, even if sometimes even on this 2 medications, they will have symptoms throughout the day, and the SABA use several times per day. The left of the table shows 40 to 59 years, 75% of FEV1 FVC ratio, 60 to 80, 70%. So that means that is the expected FEV1 FVC ratio. It varies with the age. Before we discuss the treatment of asthma treatment recommendations have recently changed. The Global Initiative for Asthma, or GINA, Guidelines 2023 now recommend the combination of an inhaled corticosteroid ICS and formoterol as the preferred as needed therapy for asthma in adults and adolescents 12 years and older. What that means, the ICS alone is no more preferred as the first therapy for asthma. Let us discuss some treatment of asthma. For the intermittent asthma, short-acting beta-2 agonist SABA as needed, which is in clinical ProAir or Ventolin 2 puff every 4 to 6 hour PR and shorter breath. And anytime use of SABA greater than 2 days per week for symptom relief generally indicates it's inadequate control and we need to do step-up treatment. But most of the time intermittent asthma are the patients who only get asthma on climate changes or on provoking factors. Next is persistent asthma. Like I discussed about GINA, low dose ICS alone is no more preferred therapy in clinically. Low dose ICS plus LABA, which would be or medium dose ICS or low dose ICS plus either leukotriene agents or theophylline. Leukotriene agents are usually singular or montelukast. The singular is on black box warning recently, but it's a preferred treatment for people who does not like inhalers. Then the next is medium dose ICS plus LABA or medium dose ICS plus either leukotriene agents or theophylline. But by the time of a low dose on the step 3 itself, we should consider about sending to pulmonologist and get a full pulmonary function test as a baseline and having follow-up. And those are low dose are the Advair in clinical phase, Advair 150, Symbicort 84.5, and a short tip for the practitioners, usually the higher dose, which is 180, those are the steroid dosages. So that's how we know that when you go to low dose, high dose, medium dose, those doses go higher up. So when you go to the step 4 medium ICS, Advair 250/50, Symbicort 164.5, Brio 102.5. And by the time that definitely we need a follow-up with the pulmonologist. And also step 5 high dose ICS plus LABA plus oral corticosteroids. And patients who have allergies, we may have to consider other alternative treatment by the pulmonologist. This is the table for inhaled corticosteroids plus LABA combination, low, medium, and high doses. You can see, as I discussed, Advair 45, Advair 115, and Advair 230. So the steroid doses go up and all the other doses remain the same. And you have some for the tip for the nurse practitioners, I have put the inhalers, the dosages. And there are 3 types of, like, HFA is there, disc is there, and then Respimat inhaler is there. So that we discuss in another video. After the treatment, we have to assess the patient, and depend upon the assessment, we classify them into well-controlled, not well-controlled, and poorly controlled asthma. Well-controlled means the symptoms, respiratory symptoms, cough, shorter breath, wheezing would be less than 2 days a week, and their FEV1, FVC ratio or FEV1 will be greater than 80%. And a SABA use will be less than 2 days a week, and there will be not like no activity limitations. Well, when we go to not well controlled, the symptoms will be 1 to 2, 3 times a week, and there will be some limitations, and the FEV1 will be 60 to 80%, and SABA use will be greater than 2 days a week. So if it is not, we are not working as in the primary care, the PFT function test won't be available all the time. So most of the time, the symptoms and the SABA would be the definition for how to we know how they are well controlled or not well controlled. Poorly controlled means the symptoms are greater than 4 times a week and their activity is limited, and SABA several times a day, and FEV1 is less than 60%. Definitely they need a follow-up with the pulmonologist. Let us summarize what we discussed so far. According to the National Institute of Health, the steps of asthma management: we diagnose asthma, assess asthma severity, mild, persistent, or intermittent, or initiate medications and demonstrate use of inhalers. There can be HFA, there can be DISC, how to use them, because that determines a lot of effectiveness. Then develop written action plan. Teach the patients how to monitor use of SABA, how many days a week, and lung function test every 1 to 2 years. Then after that phase, let us do the follow-up visits and then assess the progress they have made and praise them if they have made a good progress and they are regularly compliance with the medications, and assess them their technique adherence. If not right, because they may need a higher dose of medications. That's why the technique of administering inhalers should be right. Then teach them how to, after the use of inhaler, they have to rinse mouth, because some of the patients can get irritated or oral thrush. And then the environmental control, avoid exposure to any kind of like tobacco smoke or paint, whatever is there, irritations or feathers. And then follow up with the flu vaccine for greater than 6 months of age, and then teach them self-monitoring of their progress. And then the follow-up appointment, 2 to 6 weeks while we are trying to get the asthma under control, 1 to 6 months if it is controlled, and every 3 months if like suppose we did a step down or step up therapy, and then we need to see how they are doing or how effectively that medications are working.